ASMR anatomy series. Very excited to get into today's content. Today we'll be talking about one of the more important structures in your entire body. Not the most, but one of the most. The spinal cord. We're going to talk about the spinal cord itself, what it's composed of, the different layers, its function, all sorts of good stuff. So, let's get to it, shall we? So the spinal cord in situ, it's a posterior view with the vertebral canal windowed. So we're able to look into the back of the spinal cord right here. Here at the top, we've got the medulla oblongata. And in orienting ourselves, we've got the C1 spinal nerve at the level of the atlas. The vertebra prominens here at C7, and that cervical enlargement that we've talked about in previous videos. The T1 spinal nerve, so it tells us we're at the T1 thoracic level. And then the lumbosacral enlargement down here. T12 leading into the lumbar vertebrae down here. The L1 spinal nerve down here. And then the conus medullaris that we've talked about before, where the nerves kind of start to taper out and taper off in a greater degree. And then the cauda equina down here, which, as we've talked about before, if you haven't brushed up on your Latin recently, it means a horse's tail. So all the nerves start to really come out here, and it looks like a horse's tail. Equina being horse, if you've ever heard the word equestrian. And then cauda, it means the head or the beginning of the horse's tail. I misspoke, I'm sorry, cauda means tail. Cauda means tail. It's ceph, C-E-P-H, which means head. So this is the horse's tail, forgive me. And then the dura mater. You can kind of see the layer down here. The arachnoid mater. And then we've got the sacral hiatus, the L5 vertebra, and the S1 spinal nerve down here. And let's see what it has to say. The dura mater of the cranial cavity is composed of two layers, the periosteal and the meningeal. Only the meningeal layer extends into the vertebral canal with the spinal cord. The posterior layer of the dura terminates at the foramen magnum and is replaced in the vertebral canal with the periosteum of the vertebral bone. Due to this structural difference in the two regions, the dural sac is not adherent to the bone of the vertebral canal as it is in the cranial cavity. Okay. Now here's a different view of the spinal cord. It says the spinal cord and its meningeal layers. It says that, but it's a posterior view. The dura mater is opened and the arachnoid is sectioned. The detailed anatomy of the spinal cord can be found on 678 and 679. Those are much later pages, which we'll get to in future videos. But as you can see, the spinal cord here, we've got some white matter on the outside and gray matter on the inside. Anterior spinal artery. Anterior spinal veins in the blue. The pia mater, the arachnoid mater, and the dura mater. So you've got the three layers, the dura mater, the external, the arachnoid mater. Underneath that, the subdural space is named that. Sub means under, so under the dura, subdural space. Arachnoid mater, subarachnoid space, sub underneath again, so it's beneath the arachnoid mater. And then the pia is the closest to the spinal cord itself. So again, going in order from internal to external, pia mater, arachnoid mater, and dura mater. And the dura, you can think durable, is this thicker layer on the outside providing protection. Now, you've got the posterior root of the spinal nerves coming off, leading into a spinal ganglion. And then from that ganglion, it again bifurcates into a posterior ramus and an anterior ramus. And then the gray and white rami communicates. And then all of these together comprise the spinal nerve, which you see indicated here, C1 spinal nerve, L1 spinal nerve. That's a collection of all these different features together coming out off of the spinal cord itself. And then down here we've got the denticulate ligament and the anterior rootlets. So a lot happening in a very small amount of space, which is why you can see if there's ever an injury to the spinal cord, it can be very complicated, and in symptomology, there can be a variety of things going on or going wrong for the patient, and that's why it's important to understand your anatomy so that you can potentially understand your symptomology and make a differential diagnosis. Here's the cervical spinal cord in situ. It's a transverse section, superior view, so we're looking down on the spinal cord at the level of the C4 vertebrae. We've got epidural space, subarachnoid space, so that's going to be under the arachnoid mater, which is here. Again, these arrows are very small, sorry. The dura mater, and the posterior root, and the anterior root. We've got some vasculature here, vertebral artery, and the vertebral veins. Then denticulate ligament, providing kind of that protective layer there, and we see it here. The intervertebral foramen is what allows this spinal nerve to come out through it, and then the ganglion itself, the collection before it shoots out. Here's the cauda equina in the vertebral canal. It's a posterior view. The lamina and the posterior surface of the sacrum have been partially removed. So we're looking here from L1 down through the sacrum into the coccyx. L1 vertebrae, and it's just below that level that we experience the conus medullaris. And then down here, so we've got L1, L2, L3, L4. So it's about at the L4 level that this cauda equina begins to come into being. It's the posterior and anterior spinal roots, as you can see. And then again, for orientation purposes, the dura mater, and underneath that, the arachnoid mater. We've got the sacral hiatus and the filum terminal, which is basically the end terminal, terminate, basically the end of the spinal cord down here, or the ends of the nerve roots down here. Here's a transverse section of the cauda equina, and you can see each of these little dots, all these are all spinal nerve roots. So pretty fascinating that it comes through here, and you can see the transverse section, and then the dural sac. We can see in here, kind of encapsulating it all, your ganglion, and then your anterior internal vertebral venous plexus is at the front. So for something that is this important to our function, you're going to obviously find vasculature right around it to make sure that it's got plenty of blood supply, because veins and arteries, again, always run together. And it says fatty tissue, so you can read that as a buffer. So just make sure that if there's any impact there, it can handle it. And then down here we've got spinal cord, a dural sac, and vertebral column at different ages. Interesting. Anterior view, longitudinal growth of the spinal cord lags behind that of the vertebral column. At birth, the distal end of the spinal cord, the conus medullaris, so the far end, conus medullaris here. At birth, the distal end of the spinal cord, the conus medullaris, is at the level of the L3 vertebral body, but in the average adult, it extends to the level of L1, L2. The dural sac always extends to the upper sacrum. So what it's saying here is when you're younger, it's got a further reach down your spinal canal, and then as you get older, it kind of stays in position as your spine lengthens. Now we've got here a good old clinical box. Exciting. See, hopefully you never have to have one in your life. I haven't yet, and it's not on my to-do list, but a lumbar puncture. It's when a needle is introduced into the dural sac or the lumbar cistern, and it generally slips past the spinal nerve roots without injuring the spinal cord or spinal nerves. Cerebrospinal fluid, referred to in short as CSF, samples are therefore taken between the L3 and L4 vertebrae, seen at this level here in picture 2. Once the patient is leaned forward to separate those spinous processes of the lumbar spine. So as you remember, those processes sit over each other like this, and when you lean forward, it opens them up so that the needle can be inserted. And a lot of times these lumbar punctures are presence of any infections within the CSF, which can be a serious sign for some conditions, like meningitis is one of the primary ones, just to see if there's the presence of any infection within your meninges, which is, runs commonly through the CSF, runs through the same area. And then anesthesia, lumbar anesthesia may be administered in a similar fashion. That's at point 2 here. Epidural anesthesia is administered by placing a catheter in the epidural space without penetrating the dural sac. This may be done by passing a needle through the sacral hiatus also. So up through here through the bottom, the sacral hiatus. So if you have or you know anybody who has had an epidural for pregnancy, for the delivery of a baby, they will have that they can have that needle inserted in their back, and it's just kind of a continuous flow of anesthetic into the spinal cord to reduce some of the pain that's experienced during childbirth. So the more you know. Just another example of something interesting in relationship to the spinal cord. Alright, we got spinal cord segments and spinal nerves. Spinal cord segment. The spinal cord consists of 31 segments, each innervating a specific area of the skin or dermatome, as we talked about before, of the head, trunk, or limbs, afferent or sensory posterior rootlets, and efferent motor anterior rootlets form the posterior and anterior roots of the spinal nerve for that segment. The two roots fuse to form a mixed motor and sensory spinal nerve that exits the intervertebral foramen and immediately thereafter divides into an anterior and posterior ramus. So each one of these outlets has a specific function, is what that's saying. So your posterior rootlets here are going to be your afferent or sensory portion. It's what allows you to feel in a region. And then your anterior root, or your anterior rootlets, are going to be efferent, and that's your motor, meaning that allows movement. So you've got sensory, feeling, and motor, moving. And then you've got the posterior, they come together to form the posterior root ganglion. And then from there, you've got the spinal nerve. So you've got these two portions coming together to the ganglion and then shooting out for their sensory and motor function combined. It's all kind of rolled into one. So yeah, spinal nerve is here, posterior ramus, anterior ramus, and then the gray ramus communicans and the white ramus communicans, and then the sympathetic or paravertebral ganglion and the sympathetic trunk. The meningeal branch is here. But here we've got spinal cord segments, dermatomes, and effects of spinal cord lesions. The spinal cord is divided into 4 major regions, just kind of like your spine too. Cervical, thoracic, lumbar, and sacral. The regions of the spinal cord are designated by colors. Red is cervical, brown is thoracic, green is lumbar, and blue is sacral. So there's some at the vertebral level, you can see. And of course the coccyx down here at the bottom. And the spinal cord segments, initially spinal nerves pass out above the vertebrae for which they are numbered. However, since there is an 8th cervical spine nerve but no 8th cervical vertebrae, C8 passes out above the level of T1. And the spinal nerve for T1 and those following pass below the vertebral level for which they are numbered. So again, there are 7 cervical spinal vertebrae. There are 8 cervical spinal nerves. So it kind of creates a counting reset as C7T1. So you've got above C1, above C2, above C3, above C4, above C5, above C6, above C7, above C8, above C7, and then below C7 is C8, And then everyone after that, it's below T1, below T2, below T3, below T4, and it follows that. So the C8 kind of resets the counting. And then these dermatomes, again in review, they're band-like areas of skin receiving a sensory innervation from a single pair of spinal nerves from a single segment of the spinal cord. Note, spinal nerve C1 is purely motor. Consequently, there is no C1 dermatome. So, there you go. We always look for the rules, but there are exceptions to the rules. In this case, the exceptions are the existence of C8 and then the C1 motor only. So your dermatomes, you've got C2, C3, C4, and then down here, C8. So pretty much comprising your pinky finger. Now, this is somewhat morbid, but it also is very real. You've got the lesions, the potential lesions, or you can think lesion or also read as injury. If there are injuries at a certain cervical level, what are the consequences? So if it's a cervical cord lesion, then you're going to have total paralysis. If there's a thoracic cord lesion, then you're going to have partial paralysis. If there's a lumbar cord lesion, you're going to have severely impaired walking, but the ability to at least stand and have some faculties. And then at a conus or cauda equina lesion, you'll probably have a unilateral defect, and walking with a cane or a severe limp. Now, figure 414, the spinal nerve branches. You've got the anterior cutaneous branch. Let's see, the lateral cutaneous branches. This is a superior lateral, so we're above and looking in of a thoracic spinal nerve. The posterior dorsal rami of the spinal nerves gives rise to muscular and cutaneous branches, as well as articular branches to the zygophyseal joints. The anterior or ventral rami of the spinal nerves form the cervical plexus C1 through 4 and the brachial plexus C5 through T1, the lumbar plexus T12 through L4, and the sacral plexus L4 through S3. The anterior rami of spinal nerves T1 through T11 produce the intercostal nerves, and T12 produces the subcostal nerve. Alright, so let's take a look. It's showing the relationship that we can see at different levels. Multiple spinal nerves that follow the same pattern. So the anterior cutaneous branch is here, the lateral cutaneous branch is here, the anterior ramus, and then the posterior ramus. You've got the spinal cord itself, the spinal ganglion coming off, which again is that combination of the posterior sensory rootlets and the anterior motor rootlets coming together. So you got your ganglion here, your communicons, and just when you hear that, you can think where those junctures meet, the white and gray portions meet. The sympathetic ganglion and the sympathetic trunk coming off of that, your meningeal branch, and then you've got your medial branches and your lateral branches and your articular branches. Alright, now we're looking at a zoomed in portion here. Spinal nerve branches in the sacral foramina. Superior view of the transverse section. So, anterior roots. Got your anterior sacral foramen allowing that nerve root to go through. The anterior ramus to the sacral plexus. The posterior ramus leading to the going through the posterior sacral foramen, leading to lateral branches of the cluneal nerves. And the cauda equina, of course, too. Now, branches of spinal nerves, kind of like what we were talking about up here. This is this diagram in a chart form. So the meningeal branch covers the spinal meninges and the ligaments of the spinal column. The posterior or dorsal ramus, so your posterior ramus coming off here, leads to your medial branches, which leads to the articular, muscular, and cutaneous branches. Articular branches take care of the zygophyseal joints. The muscular branches take care of the intrinsic back muscles. And then the lateral branches and the medial branches branches come together, forming the cutaneous branch, which covers the skin of the posterior head, neck, back, and buttocks. You also have the muscular branch of the lateral branches, which lead to the intrinsic back muscles as well. So both the medial and the lateral take care of intrinsic back muscles. And then the ventral ramus, lateral cutaneous branches, skin of the lateral chest wall, anterior cutaneous branches, skin of the anterior chest wall. Pretty intuitive, but you have to know it to begin with and be able to intuit it. And then these the little asterisk on the white and gray communicons. The white and gray rami communicons carry pre and post ganglionic fibers between the sympathetic trunk and the spinal nerves. Let's take a look here. I think we'll go through the arteries and the veins of the spinal cord, and then we will probably call it quits for this video, but let's at least go through this first, right? Alright, like the spinal cord itself, the arteries and veins of the spinal cord consist of multiple horizontal systems, blood vessels of the spinal cord segment that are integrated into a vertical system. So, for the arteries of the spinal cord, the unpaired anterior and paired posterior spinal arteries typically arise from the vertebral arteries. As they descend within the vertebral canal, the spinal arteries are reinforced by anterior and posterior segmental medullary arteries. Say that 5 times fast. Depending on the spinal level, these reinforcing branches may arise from the vertebral, ascending, or deep cervical, posterior intercostal, lumbar, or lateral sacral arteries. Alright, there's a lot there. So here at the top you can see your basilar artery, which I always usually remember because it's at the base of the brain. The vertebral artery, anterior spinal artery, posterior spinal artery. Another look at the vertebral artery here. Ascending cervical artery, posterior segmental medullary artery, subclavian artery, which is one of the main branches off of the aorta itself, which is what we see here. The segmental artery over here, the posterior intercostal arteries, so that's going to go to your ribs. Your posterior segmental medullary artery, greater anterior segmental medullary artery, and then your lumbar arteries coming out at the lumbar section off of the abdominal aorta here. So you've got abdominal aorta here, primary aorta here, and then sitting right here is going to be the heart, which has been transected for us to be able to look here, and it's listed as the arterial supply system. Now, we've got the spinal and segmental medullary arteries over here, so you can see, and this is what provides vasculature to the bone, to your vertebrae. But you've got your posterior spinal arteries here, the posterior horn, anterior horn, the spinal branch, the sulcal artery, which hangs out in the sulcus. So I imagine it wasn't super hard for them to name that. And then the anterior spinal artery, the vasocorona. When you hear corona, think crown. So it's like a crown on the top here. The posterior segmental medullary artery and the anterior segmental medullary artery. Down here in figure B, we've got origins of the segmental medullary artery. In the thorax, the segmental medullary arteries arise from the spinal branch of the posterior intercostal arteries. Okay. Now, let's get over here to the veins of the spinal cord. The spinal cord drains via venous plexuses into an anterior and a posterior spinal vein. The radicular and spinal veins connect the veins of the spinal cord with the internal vertebral venous plexus. The intervertebral and basovertebral veins connect the internal and external venous plexuses, which drains into the azygous system. Alright, let's take a look. We'll start out over here in figure A with the venous drainage system. So right deep cervical vein, anterior spinal vein, right vertebral internal jugular, so that's going to carry a lot of the blood supply deoxygenated from your brain down to the heart for reoxygenation in the lungs. The left brachiocephalic vein, the accessory hemiazygous vein. There's the superior vena cava, which is when the superior vena cava is basically the equivalent of the aortic arch over here. Intercostal veins, posterior radicular vein, anterior radicular vein, hemiazygous vein, which leads back up to that azygous. They all connect, I should say. Azygous vein, anterior spinal vein, ascending lumbar vein, inferior vena cava, and the common iliac vein. Now, taking a look here at the vertebral structures, kind of like what we did here, we were doing that with the veins. So you've got a venous ring instead of the vasa corona. You've got a venous ring. You've got a sulcal vein. You've got the spinal vein, the anterior spinal vein, the anterior radicular vein, and getting down to how it relates to the vertebrae themselves. Posterior internal vertebral venous plexus, anterior internal vertebral plexus. So anterior being this way, and then posterior being further back on the spinous process. Subcostal vein, ascending lumbar vein, anterior external vertebral venous plexus. So anterior external, anterior internal, and then you've got your basal vertebral vein, which is in the base of the vertebrae, base vertebral in the vertebrae itself. So it's taking away deoxygenated blood from within the vertebrae. Intervertebral vein, you can see here, posterior internal vertebral venous plexus in the epidural space. So it's outside the dura. And as you remember, the dura is the most external layer of the spinal cord. Ascending lumbar vein, medial and lateral epidural veins, basivertebral vein, anterior internal vertebral venous plexus, the internal iliac is on the other side of the sacrum here, and the external iliac we can see poking out under the sacrum, leading back up. And these are the veins in the sacral and lumbar canals. That's what we see here. So, we've covered the spinal cord, or the first part of the spinal cord, and we've covered the arteries and the veins in the spinal cord. And then we'll get into, next time, it'll be the neurovascular topography of the back. Okay? So we've seen a lot of the primary branches here, and some of the more nuanced branches around the spinal cord itself. And then we're going to get into some of the very distal or further out branches, get to some of the indestinations when it comes to the external and intrinsic muscles of the back, and the blood supply for each of these regions, and the innervation of these regions, how the veins and arteries run together, and how important those relationships are, especially whenever, again, it comes to kind of like the clinical issues that you might see. If you know that these different things run together, then if you know there's damage to the blood supply there, then there could be problems with the nerves as well. So that's why it's so important to know and understand these relationships in proximity to one another. As always, guys, thank you for taking the time to spend with me. I know there's a lot of people making a lot of good content, and yet here you are watching this video with me. So if you like it, please like it and subscribe so that I can make more videos like this. As always, any feedback is welcomed if there's anything you'd like to see more of. And I hope everybody's New Year is going well so far. I know there's a lot of